Dr. Kashi, for this warm introduction. Good morning, everyone. I'm going to talk on current concepts of MOG optic neuritis. I wish I could say that I have a financial disclosure, but no. So we are all very aware that ever since the discovery of these zero markers have come into the literature, management of optic neuritis is having more clarity, and I'm going to discuss the MOG optic neuritis in this particular talk. And this zero marker positivity and MOG antibody characterization is very clear about the demographic nature, optic nerve characters, and the imaging aspects of MOG optic neuritis. So MOG optic neuritis can be a spectrum of disease. It can be a isolated optic neuritis or a myelitis, multifocal CNS demyelination, or ADEM, which is more commonly seen in pediatric age group. And the MOG optic neuritis can be bilateral, recurrent, with severe disc edema, with a perineural enhancement on MRI, and it can affect any age group, and mostly it is in the third decade, and men and women are equally involved, and the presence of severe vision loss, which usually responds well, unlike the NMO spectrum disorders, is characteristic of a MOG. But as the relapses increases, we have to be cautious because we may not get the same type of recovery. And coming to the imaging characters, we can see this type of, I think the cursor, yep, there it is. So you can see this type of anterior long signals along the optic nerve, which have a characteristic perineural enhancement that is typical for an optic neuritis, and they very seldom engage the chiasm and the posterior aspect of the optic nerve. And these are the fluffy brain lesions, which can be hyperintense and mostly less than 3 millimeter, and they don't occupy the areas like Dawson's fingers areas, S and U type of lesion. They usually involve the thalamic, pontine, and cerebellar peduncle regions. And the MRI spine will show the classical head sign, and sometimes we can also see a long segment involving lesions in a MOG2. And serum MOG antibody testing, ideal is to do a live cell-based assay, which is a characteristic pattern of assessment, but we also have fixed cell-based assays which are available. And false positivity is quite common when we use a low dilution, and high titers can cause a relapsing event of optic neuritis, and sometimes negative report is equalizing to a disease recovery. And persisting high titers, as I mentioned, is a poor prognostic factor, and it also predicts the relapses of the patient, which can happen down the line when you are going to taper down the medications. And the positive predictive value of a MOG testing will definitely vary depending on the epidemiological background to certain extent. And ever since Brenda et al. Had come up with this diagnostic criteria for MOGED, it is quite clear what type of optic neuritis we are going to brand as a MOGED spectrum of optic neuritis. And regarding the timing of the MOG testing in this particular study has said that although we follow this three-step approach of having the core clinical and the supportive evidence and a positive cell-based assay MOG titers, sometimes we may have a clinical and a radiological features suggestive of a MOGED, but the titers may be low. So in spite of that, we do make a diagnosis of MOGED, because 25% of the patients can become low positive by 6 months, and by 1 year, 50% of them will totally be seronegative after the disease onset. So the clear high titer positivity, particularly in the IgG1, is considered within 1 month of the onset of the clinical features, is considered to be very pathognomonic of a MOGED. And pre-treatment steroids, this study showed that did not significantly affect the MOG results. And this particular study has shown the conversion of from laboratory to the real world experience of the IgG positivity of MOGED. They said that the low MOG positivity has definitely have some diagnostic implications, which mean a patient, this study involved the cell-based fixed assay, the Euroimmune kit. And they showed that the MOGED criteria was met only by 35% of the 35 patients among the low strength positives in this group, whereas if there are high strength positives, most of them had a MOGED diagnostic criteria to be positive. And this study diagnosed the various CSF markers in NMO and MOGED and tried to imply their clinical use. These CSF samples were analyzed for GFAP, the albumin quotient, and all this other markers, and they found that MOGAD patients had high CSF lymphocyte counts with elevated lymphocyte counts, particularly correlating with a polyphasic event. MOGAD can be even a multiple relapsing events, unlike the children where they will have more of ADEM presentation. So the antibody profiling of these regarding the MOGAD, NMO and the double seronegative, these groups they also used to predict the seromarkers for the recovery of the optic neuritis. Of the 47 patients what they included, they found that the MOG status was associated with a higher quality of visual improvement unlike the NMO spectrum disorders. And severe visual disability, they concluded that it's very less frequent in MOG spectrum disease unlike NMO spectrum. And this is the new thing which is being discussed in the literature, MOG patients showing a raised CSF pressure. This is also being reported in the study that of the 28 MOGAD cases, almost many of them had 26 to 46 centimeters of CSF pressure when they tried to tap. So this has to be kept in mind, particularly when the patient is going to come with optic neuritis and features of meningoencephalitis, because that is the time when the CSF pressure has been recorded to be high in this group of patients. So coming to the treatment of demyelinating optic neuritis, yes, all of them will require an acute treatment and a chronic treatment. If it is going to be an acute treatment, it is invariably intravenous steroid, and if it is a chronic treatment, we need a long-term maintenance immunosuppression. And this is a nice algorithm which is given in one of the neurology articles, where they said that after that acute event, if the diagnosis of MOGAD is confirmed, go ahead with the IV steroid and plex them if they are going to be as early as possible. Earlier it was described more for NMO, but now even plex is being a choice for MOGAD patients if they are going to have no recovery by 1 week or so. And the preventive maintenance therapy can be depending on the persistent MOG titers. If the MOG titers are quite high, then better to keep them on a chronic immunosuppression, which can range from oral prednisolone to oral immunosuppression or a pulsed IVIG cycles or even a monoclonal antibodies. Because this is the group of disease which when you come down on steroids, the patient will boomerang back with a relapsed attack of neuritis. So we have to keep such patients for a chronic immunosuppression. And as I have discussed on this, this is a nice article where John et al. Had compared all the possible options for plasma exchange of all optic neuritis, and they also conclude that MOG disease or optic neuritis within a month has a better choice for plex therapy, and older age, delayed treatment and poor vision at onset will be poor response predictors. And these are other types of immunosuppression which are involved in MOGAD, where IVIG and Mycept had a reduced ARR rate. And this is another studies which compared use of rituximab in MOGAD versus NMO, and they found that rituximab had a better control of NMO spectrum disorders rather than a MOGAD, but IVIG is one option which can also reduce the relapse rate in MOGAD. And there are a lot of IL-6 inhibitors also which are being used, but I think our part of the world, it is not so much in practice. And this is a study which has come up, which is an open label single arm study in the literature, where they have tried tocilizumab for patients who are refractile for MOG spectrum disorders, and particularly for the optic neuritis. And they found that the relapse rate was significantly low in 7 of their patients when they had given options of tocilizumab. So there are options of optic neuritis beyond MOG also in this part of the world. Elderly age group, painless or painful vision loss, severe disc edema with lot of hemorrhages and cottonwool spots, progression of visual loss beyond 2 weeks, poor response to treatment, severe recurrences with steroid dependence, and a lot of autoimmune diseases can be along attached with these group of disease, starting from SLE to GPA to IgG4, Behçet's or sarcoid. We have to be very cautious. So we do an extensive blood workup when we are going to plan for this type of chronic immunosuppression therapy for all this group of patients. And these are the lists what we routinely practice in our setup. I'm going to show one case example where a 66-year-old female came with a complaint of sudden painful vision drop in the right eye over a period of 3 days. And she was diabetic and hypertensive. There were no signs of giant cell arteritis or raised ICP, and she did not have any other systemic illness. And her visual acuity in the right eye was almost counting fingers closed phase, and that of the left eye parameters were normal. You could see that a very subtle disc edema with a splinter hemorrhage, and the vision was counting fingers closed phase at 60 plus age group. Now I revisit my diagnosis of all the ischemic optic neuritis what I have made in the past. So because after this MOG, we are very skeptical in making this type of diagnosis. So this is the imaging character where you can see a long sheath enhancing signal along the right side, and that is a diffuse thickening of the T2 with an enhancement of the right, which you can see as a classical perineuritis. So the patient also had few hyperintense signals in the deep cortical matter, but they were mostly small vessel ischemic changes. So we did our routine labs for her, and most of them were negative, and she was negative for all the autoimmune granulomatous and all the spectrum disorders, but these two came positive. So she's got a HRCT having nodes, she's positive for MOG, she's positive for quantiferon. So now what do I do? So we involved an infectious disease consultant and a neurologist. We went ahead for a CSF. The pressure was normal, the analysis was normal. Her gene expert CSF was negative as usual. So she was treated with intravenous steroids and tapering steroids along with a course of antitubercular treatment. So we don't have a choice. When we have these two positive in a 60 plus, and I'm going to keep her, if she's going to come back with the relapse, I don't have a choice, I have to escalate my immunosuppression for her. So post-treatment, she did recover from counting fingers to almost 618 by 2 weeks, and she recovered by 3 months to 6-9, and she's still on antituberculous treatment. So in our part of the world, when we are going to consider for a chronic immunosuppression, always do rule out all the spectrum of infectious diseases, because that's going to give us a lot of problem than the immunosuppression per se. And in the literature also, there are a lot of differences, and this is an article which compared white versus Asian race MOGAD spectrum, and they found that non-Asian population had more recurrent, painful, and bilateral involvement, and the vision outcome and clinical features were almost similar, but MOGAD most of the time had a limited optic neuritis in Asians. And we tried to analyze our population in our center, and we tried to do all the optic neuritis with and without seromarkers. We compared their clinical behavior, and this was a retrospective data of 203 patients, and we excluded all other causes of optic neuritis, optic neuropathies, and we found that we had most of our MOG optic neuritis presenting with a disc edema, and that of the analysis, most of them had a seronegative. So double negative was high in our group of people, followed by the MOG optic neuritis, and then the NMO, and MS was very less in our part of the optic neuritis patients. So to conclude, MOGAD diagnosis is very clear, and the diagnostic criteria in 2023 has helped us and refined the management of MOGAD. Acute treatment will involve intravenous steroid followed by a slow, long oral taper of steroids, and ADEM is very common in children, but optic neuritis is common in adults, and clinical and imaging features will request for a MOG antibody testing, and we always nowadays we do, even with the first attack, we are doing all the seromarkers, because the access for these seromarker analysis is not available throughout India in all the places. Poor recovery and higher relapses and consistently high MOG titer will warrant a long-term immunosuppression. It's always better to rule out other infective etiologies before putting these patients on chronic immunosuppression, and probably we need a lot of prospective RCTs to find out how long we continue this immunosuppression in these patients and when to stop. Thank you so much.
That was an excellent